metabolism and pediatric endocrinology, and concurrently did the investigative medicine program here and received her PhD during that time as well. She serves as a medical director for the Yale Stress Center. She's a co-director of the Yale Center for Weight Management and is the director of the new Yale Obesity Research Center, the Y Weight Center. She has numerous honors and awards. She was recently elected as a Clinician of the Year by the Obesity Society. She serves as an associate editor for Diabetes Care, which is one of the major diabetes clinical journals, and has also sponsored numerous NIH workshops focused on advancing interventions for adult obesity. She also has multiple R01s related to her presentation today on GLP-1s and is investigating their effects on food cues, stress interventions for obesity. And she's also led numerous phase 2 and phase 3 randomized controlled trials on GLP-1s and other pharmacologic therapies for weight gain, obesity. And I think she only chooses to publish in the New England Journal of Medicine. She's had 2 in the last 2 years focused on demonstrating the impact of these drugs on weight loss, and it is really revolutionizing the way that we care for patients with weight gain and obesity. And her talk today is nutrient-stimulated hormone-based therapies for the treatment of obesities, sparks from the pipeline. Welcome, Ania. Thank you.
Thank you so much for the introduction, and it's so great to share medical schools together, so that's a super fun fact. Maybe we won't talk about art history today, maybe another day. So these are my disclosures. They're all related to the exciting field of obesity medicine. You should know that I do consult for companies that make these medications. I will also mention some off-label use of anti-obesity medications. So we're all here because we want to help our patients lead healthier lives. And just a striking fact is that by 2030, nearly half of Americans will have obesity. Now, I share this partly because the question is, how is that possible? And clearly, none of us are choosing to have this disease. So why is it? And I see so many patients that ask, well, you know, I can lose weight, but it's so difficult to keep that weight off. And the question is, why is that? So before I delve into the medicines, I'm just going to give you a little sneak, an overview of what may be going on in terms of pathophysiology. So why is it so difficult to lose weight and maintain weight loss? Well, if you think about it, our body has designed this beautiful system. This system evolved over time to basically inform how much energy we should carry. So we have hormones that signal to our brain to make sure that we have enough energy. Now, our bodies store this energy as fat, and that's really important, right? Because if we don't have enough energy to do the things we need to do, we would starve. And if we have too much energy and we have too much fat, we also can't do the things that we need to do in our daily lives. So our brain defends a certain amount of fat, and we call that the defended fat mass, or some people call it the set point. Now, if we think about it, we may say, well, why is it that we have this beautiful system? Why do so many people have obesity? Well, it turns out within our obesogenic environment, the system has become dysregulated. Some may argue it's actually working exactly as it should, but on a population level, in the current obesogenic environment, this has been driven up. So let's look at this in another way. So here you have a house, and the house has a thermostat. In this room in particular, the thermostat is broken, and it is not set to 70 degrees Fahrenheit. It's probably set to 80. Okay, so let's say you have a house and the thermostat is working, and it's set to 70 degrees Fahrenheit. Oh, and for those of you online, it's exceedingly hot in here. So you have the sun. It is hot outside. It is summer. So what happens? The thermostat is like, oh, it's hot outside. I better turn on the air conditioner. So the air conditioner turns on, and this is not conscious. We're not walking over to the thermostat. We're not adjusting anything. It just happens. And so what happens if it is cold outside? Well, the opposite happens. The furnace turns on. But now pretend that it's the middle of summer. It is July or August, and it is exceedingly hot. Well, what happens is that temperature set point of 70 degrees becomes harder and harder to maintain. And it turns out, of course, our body does this with many functions to try and maintain a certain set point. And we call that homeostasis. So it's not just body temperature, it's not just immune function or electrolyte balance. It turns out it's also body fat mass. So now let's look at our bodies. So now our brain is the thermostat, and it tries to defend this certain amount of fat mass or this amount of energy that we need to carry in order to not starve and to be able to do the things we need to do. And so what happens is that when we gain weight, or specifically when we gain fat mass, this signals to our brain through various hormones that now we're really getting to know a lot better. GLP-1 is one of them and GIP is another. It signals, hey, increase thermogenesis and decrease appetite. That's what should happen, right? And the opposite should happen if we lose weight or if we lose fat mass. So now imagine that you have an obesogenic environment, which is exactly what we're in right now. So an environment that is filled with highly processed food that's available 24 hours a day, a lot of stress, a lot of issues in terms of lack of physical activity, and in terms of the lack of the ability to actually be able to do what we're quote unquote supposed to do. We can't control all these factors. This is our environment. So stress, lack of sleep, lack of physical activity, and this highly ubiquitous, highly processed foods. This is all our obesogenic environment. And now what happens is that defended fat mass set point gets pushed up on a population level. And why is this important? This is important because when we think about obesity and what it really is, obesity results from an inappropriate or a pathological or pathophysiological setting or dysregulation of that defended fat mass. And so what does that mean in terms of treatment? That means that any treatment that we implement for obesity requires resetting or re-regulation of that defended fat mass. And this is a paradigm shift for many, right? We didn't know this for years. And we were constantly asking people to eat less and move more. But your brain is controlling how much energy you carry. So you can do that, but eventually your body fights back and your body gains back that weight. Okay, so if the goal of treating obesity is to decrease or re-regulate that defended fat mass, then all these things are driving up that defended fat mass, then what do we think anti-obesity medications are doing? Well, we think they're somehow driving that defended fat mass down, or they're helping to re-regulate that defended fat mass. So helping us to want to store less fat or less energy. So how are these medications doing this? Well, that's the million-dollar question. We also don't know exactly how that defended fat mass set point is set in our brain. We don't know on a molecular level, and there's a lot of research being done to try and figure that out. But what we do know is the majority of these anti-obesity medications, they work in the brain. So most of the medicines that I'm going to show you today, there's receptors in the brain. And so it makes sense. If your brain decides how much fat mass to carry, and these medicines are working in the brain on those regions, then we think that's likely how they're working. Now, one medicine you don't see up here is orlistat. Now, orlistat helps people absorb less fat. We do not think it works centrally, and it's not up here on this list, and that's the only one. Okay, so here's kind of, that was the background in terms of the physiology. And here we are in this really transformational time. So this time where for years we've been trying to help people in terms of losing weight, but we weren't actually targeting that obesity pathophysiology. And here we are, brought on by the recent introduction of these highly effective anti-obesity medications, now potentially able to care for people with obesity in a completely different way. And to illustrate this transformation, I'm going to show you two patients. One who was treated with the older medications that we still have and still use, and one who was treated with the new medications. So the first patient is an 18-year-old. When I saw her, her BMI was 57. She already had several obesity-related diseases, and even at age 18, she had mild obstructive sleep apnea. So what did we do? So over the course of about 3 to 4 years, we started several medications. So metformin, liraglutide, bupropion, naltrexone. And this combination, again, this took about 3 to 4 years. Through that combination, she was able to lose almost 140 pounds, losing about 45% of her body weight. Her BMI came down to 31 and her A1C normalized. Now, since that time, she's actually gotten down to a BMI of 25, and she's doing great. So with these previous medications, 4 agents, about 45% for this particular patient. And by the way, her OSA resolved, and as did her prediabetes. So here we have a second patient. She's a 49-year-old female. When she came to see me, her BMI was 34. Now, over the course of her lifetime, you can see that she had tried every diet and every intervention under the sun. And guess what? She was highly effective at losing weight. She was tracking every morsel of food that she ate for her whole life, but every time she gained it back. So when she came to see us, she also had some obesity-related diseases. Her BMI was 34, and we enrolled her in a clinical trial of Tirzepatide versus placebo. And this is what happened over the course of a year. So within 1 year, she lost over 90 pounds. She lost about 45% of her body weight, and her BMI came down to 20. She actually did not feel comfortable with this BMI. She finished out the trial, and then we helped her, and she's now around a BMI of 25 to 27 and doing really great. So next generation medications, 1 agent, 45% in this particular patient. And so really, we are at this watershed moment brought on by the recent introduction of these highly effective anti-obesity medications. We had the medications that I showed you. We still have them. We use them in combination. We can help our patients achieve their health goals. But now with semaglutide and tirzepatide, this has heralded the development of all of these other agents. Now, the ones that I'm focusing in on are nutrient-stimulated hormone-based therapies, or NUSHs, medications like semaglutide and tirzepatide. But know that there are many other mechanisms being explored. So there are activin receptor inhibitors. These medications help people decrease their fat mass, but also potentially help preserve or increase muscle mass. And these are in development in phase 2. There's an MC4R agonist that's already FDA approved for the treatment of monogenic forms of obesity. It's called setmelanotide. And there are many, many other mechanisms being explored. So this is the tip of the iceberg. Okay, so let's focus in on NUSHs, or nutrient-stimulated hormone-based therapies. So what are nutrient-stimulated hormones? Well, they're any hormone that is secreted or stimulated, I should say, when we eat food. Now, these hormones, basically, when we eat food, they signal to our brain, as well as other tissues in our body, about energy homeostasis. They signal about satiety, potentially about energy expenditure, and they help with that defended fat mass that we just talked about. So how are we using these? Well, the GLP-1 is the most commonly referred to nutrient-stimulated hormone, and that's because GLP-1 receptor agonists have been used for the treatment of type 2 diabetes for nearly 20 years. And now, as you can see, GLP-1 is being formulated as dual agonists, as triple agonists, with other nutrient-stimulated hormones such as glucagon, amylin, and GIP. Now, GIP and GLP-1 are the only 2 incretin hormones, because you might ask, well, aren't these all just incretins? They're not. So glucagon, for example, is stimulated by amino acids or protein, whereas GLP-1 and GIP are stimulated by glucose and stimulate insulin release. Now, why wouldn't we just call them GLP-1 based medications? Well, that's because not all of them are being paired with GLP-1. So for example, PYY and amylin are being formulated as monotherapies for the treatment of obesity. Okay, so this next slide I update almost daily. It gives you a glimpse of all the nutrient-stimulated hormone-based therapies that are in development, that are currently in phase 2 or phase 3. Now, if you double or triple this, that's how many are in phase 1. So again, this is the tip of the iceberg. I'm just focusing in today on the ones that are in phase 3 and the 2 that are FDA approved already for the treatment of obesity. Okay, and that's semaglutide and tirzepatide. So let's start with semaglutide. So semaglutide was FDA approved originally for the treatment of type 2 diabetes in 2017. Then for the indication of chronic weight management or obesity in 2021 for adults, and then in 2022 for adolescents. Now, semaglutide is a once-weekly injectable medication, self-injectable. It is a long-acting GLP-1 receptor agonist. Now, this was the first medication in this class that really demonstrated this average weight reduction that was, very significant of 16.9% on treatment. This translated to 34 pounds of weight reduction at 68 weeks. Now, as I'm speaking about these medications, make sure to focus on the duration of the trial. So this was just over a year, but know that it may take longer to achieve the weight plateau depending on the efficacy of the agent. Okay, so this was highly significant. In the STEP Teens trial, we also found that teen participants aged 12 and above with severe obesity were also able to lose a significant amount of weight with significant change in BMI. Currently ongoing is the STEP Young trial. We're a part of this trial as well. It is looking at semaglutide for children age 6 and above. Now, some may take pause with this and say, wow, that's pretty young. Well, just to give you an idea, these are children with severe obesity. So imagine a 6-year-old who weighs 70 kilograms. So these are the children that were enrolling in the trial. Now, I have an R01, as was mentioned, with semaglutide. I'll tell you very, very briefly about that. Now, additionally, in all these trials, what we're seeing is improvements in cardiometabolic measures, so A1C, blood pressure, and cholesterol. And the question has been, well, do these improvements in measurements actually translate to health improvements? And the answer is yes. And the first evidence of that in a very big scale way is the SELECT trial, which we were also a part of here at Yale. So in the SELECT trial, we enrolled over 17,000 individuals with obesity without type 2 diabetes, and they were randomized to receive either semaglutide titrated up to a dose of 2.4 versus placebo. And this was really significant because all the cardiovascular outcomes trials to date, most of them have been done in people with diabetes, but now we wanted to look at this in people with obesity. And what was found in the SELECT trial was a 20% reduction in 3-point MACE, so cardiovascular death, non-fatal MI, and non-fatal stroke. And this is really very significant, especially considering that this population was already treated very well, meaning that they were, most of them were taking statins, they were on antiplatelet therapy, they were on antihypertensives, and well controlled. And so this was very significant. And now actually it's led to Medicare approving semaglutide 2.4 for its beneficiaries if they have cardiovascular disease. Now, what about heart failure? So STEP HFpEF, which is heart failure with preserved ejection fraction. This trial also recently read out and demonstrated significant reduction in heart failure symptoms and physical limitations, and also found was that the magnitude of the benefit was directly related to the extent of the weight reduction. Now, what about the kidney? Is there benefit there? Well, recently the FLOW trial was discontinued. This is a trial looking at individuals with type 2 diabetes, and the trial was terminated early because of efficacy, meaning that it would have been unethical to continue the placebo group because it was so effective. So the top line results, we don't have the final results yet, was that there was a 24% reduction in the risk of kidney disease and progression and kidney and cardiovascular death. So very briefly, just to share with you about the R01, there's a beautiful team working on this from the Yale Stress Center, as well as coincidentally from pediatric endocrinology. Although this is an adult trial, we have some amazing investigators and clinicians that work on this R01 with Rajita Sinha and I. And basically, we're looking at the impact of semaglutide on metabolic and stress responses, and we're trying to see whether we are able to discern who is losing weight. We're looking at craving, hunger, food consumption, and we're looking at this in a lab-based task as well as real-world food intake. So we actually have people come in at multiple time points to assess if they're snacking even when they're no longer hungry, and we're looking at this on as well as off when they come off the drug. So this is in year 4, so hopefully I'll be back to tell you about the results soon. Okay, so that's semaglutide. What about tirzepatide? So tirzepatide was FDA approved for type 2 diabetes treatment in 2022, and then most recently for obesity in 2023. Now, tirzepatide is one molecule. It's a GIP GLP-1 receptor agonist. It is also a once-weekly self-injectable medication. And I was very honored to lead this trial, the SURMOUNT-1 trial, where we looked at participants with obesity And what we found was that with the highest dose of tirzepatide, 15 milligrams, the average weight reduction was 22.5% at 72 weeks. Now, what this translated to was an average weight reduction of 52 pounds at that time point. Additionally, we found that nearly 40% of participants lost at least a quarter of their body weight. So what does that mean? That means that if a participant started the trial weighing 200 pounds, they were able to lose down to 150 pounds. So really significant results. And additionally, in this trial, we saw marked improvements in cardiometabolic measures, including A1C, blood pressure, and cholesterol. And just remember, none of these participants had type 2 diabetes. About 40% of them did have prediabetes, but basically we're helping normal to get even more normal in terms of these parameters. And now there are ongoing trials to see how that translates into improvements in health. Now, one of the things we noted in this trial, as I mentioned to you to watch for those time points, is we weren't sure whether that 10 and 15 milligram dose actually achieved weight plateau, meaning were people actually reaching their maximum weight reduction in terms of percent in this trial. And we have the answer with SURMOUNT-4, which was longer. This was 88 weeks. So in this trial, all participants for the first 36 weeks received tirzepatide, maximum tolerated dose, 10 or 15 milligrams. And then at the 36-week time point, they were randomized to receive either placebo or tirzepatide. And what we found was that when tirzepatide was continued for those 88 weeks, the average weight reduction was actually 26%. And the average absolute weight reduction was 62 pounds, and now half of participants achieved at least 25% weight reduction. So you remember when it was shorter, it was 40% of participants, and now we have over half. And so what we learned from this trial are a couple of things. One is that the weight plateau, the more efficacious or effective an agent may be, may take longer to attain. And in this case, it looks like it's about 76 weeks. And that weight regain occurs when the medication is stopped. Now, this has previously been shown. For example, the step 1 extension, which was Semaglutide 2.4, also demonstrated weight regain when the medication was discontinued. Now, this really comes to the point of obesity is a chronic disease. So let's say you have a patient with hypertension. If you give them an antihypertensive, what happens? Hopefully their blood pressure improves. Now, what happens if you stop that antihypertensive medication? What happens to their blood pressure? It goes back up. And we're not surprised. We're like, why would we stop the antihypertensive? And yet for weight, we think, well, I don't think I've ever had a patient who doesn't ask to stop the medicine. Somehow we think, oh, once we've lost the weight, somehow the obesity goes away. But again, it's a dysregulation of that defended fat mass or set point. So when we stop the medication, what happens? That defended fat mass goes back up and our body chases it and weight regain occurs. Now, there's a caveat here. There's variability in terms of how much weight people regain, just like there's variability in terms of how much weight people lose. And we really need to learn more about both. And I'll show you some of the variability in terms of weight reduction. And hopefully at some point soon, we'll have more information about weight regain. But on average, most people gain most of it back. Okay, so where are we with tirzepatide? Well, the SURMOUNT-1 trial, I showed you the results, but it's ongoing for those 40% of participants who had prediabetes in the prediabetes extension. SURMOUNT-2 was in individuals with type 2 diabetes, and it demonstrated marked improvements in hemoglobin A1C. Now, SURMOUNT-3 looked at tirzepatide after intensive lifestyle intervention, and you can see that the weight reduction was about 26.6%, compared to SURMOUNT-4 that I just showed you, which did not have intensive lifestyle intervention, which demonstrated a weight reduction of 26%. So one might ask, well, then what is the role of lifestyle or intensive lifestyle intervention? Well, I'll say this, that the weight reduction is being driven by the medications. But when we're talking about optimizing health, nutrition and physical activity are key. So these need to be used together. So when I see patients in clinic, when we're about to start these medications, we talk about, okay, if you respond to this, you'll be eating a lot less during that weight reduction phase. How do we help you maximize protein intake, just as we would after bariatric surgery? How do we help you maximize fruits and vegetable intake? So again, for the weight reduction itself, the medication is helping to decrease or re-regulate that defended fat mass set point, but for optimizing health, we really need both. SURMOUNT-MMO is the primary and secondary cardiovascular prevention trial, so CVOT for tirzepatide. Now, this is unique because SELECT looked at secondary cardiovascular prevention, whereas this is looking at both primary and secondary. So anxiously awaiting that trial, and it's ongoing. It's also looking at kidney outcomes. Now, I couldn't give a talk to all of you without talking a little bit about its effects on obstructive sleep apnea. So Tirzepatide is being looked at in the SURMOUNT OSA trial. This trial enrolled participants with obesity with established obstructive sleep apnea, and basically it randomized them to Tirzepatide versus placebo max tolerated dose. Now, they did this in a way where they basically enrolled patients who were not on PAP, and these were basically patients who either were unwilling or unable to start that therapy. And then the second cohort was already on PAP for at least 3 months. And then each of those was randomized to either placebo or Tirzepatide. Oops. And they enrolled over 450 participants. 30% of them were female, so they capped men at 70% for this trial. Just for context, most obesity trials, they mostly enroll women. That is who comes, and so we usually cap women. In this case, obviously, because of OSA, the cap was in men. Average age was nearly 50, average BMI was 38.8, and there was a roughly even distribution between class 1, 2, 3 obesity. If you want to know the results, then tune in, either live stream or come in person to the American Diabetes Association. The results will be presented on June 21st, 2024, and I looked in the program and it is now in there, so we can say that. Otherwise, if you want to know more about baseline characteristics or anything about the trial, you can go to the baseline paper, which is already published down below with the reference. Okay. So we talked about these medications, and before I tell you about the ones that are in the pipeline, I want to just speak for a moment about tolerability. So GLP-1 receptor agonists, as I mentioned, have been used for the treatment of type 2 diabetes for nearly 20 years. So we have information about tolerability as well as safety in people with type 2 diabetes, 90% of whom have obesity. So what are the most common side effects? Well, they're gastrointestinal. They include nausea, diarrhea, constipation, and if we titrate too quickly, vomiting. Now, these GI side effects are transient, and they only, or mainly, I should say, occur during dose escalation. So there are rare patients where these persist, but for a majority of patients, it's as they are starting these medications. And so what is the best way that we have of mitigating these side effects? It is slow up titration of these medications. We need to individualize the therapy for each patient. So the mantra to remember, it's really easy, is start low and go slow. So what do I mean by that? So if a patient is GLP-1 naive, they're not taking any GLP-1 receptor agonist or any medication in this class of nutrient-stimulated hormones, start with the lowest dose, always. And I think many of you will be using these medications if you're not already using them. And so just always remember, start with the lowest dose. Now, if you look at the late package labels, it says you can go up after a month. But there's nothing that says that you have to. Just like if you have a patient who has hypertension, it's not like you have to titrate them up at a certain speed. And it's the same thing with these medications. So start low and go slow. As an example, if I have a patient in clinic and they are experiencing nausea, and let's say they're on the second dose of Semaglutide or Tirzepatide, I do not go up. Like, vomiting is something that we want to avoid at all costs. So if they're having nausea, just keep them on that dose, or if they're having significant nausea, lower the dose and go slow. And just remind, because our patients are often very eager, right? They're eager to actually go up on the dose so that they see more weight reduction with the doses. Just say, we're here to help you. We're here to keep you safe. And the weight took potentially years to come on. And we're going to help you with your weight reduction over a shorter period of time than that weight, but it didn't come on overnight, and we don't want it to come off overnight. That can potentially lead to negative effects that we see with other interventions. Okay, so start low and go slow. That is the answer, and that's my message about that. Okay, so let's go on to some of the medications that are in the pipeline so you have a glimpse of what's to come. So the next medication to come is CagriSema. So cagrilintide is an amylin analog, and it is being paired with semaglutide, the GLP-1 receptor agonist. This is also administered once weekly as a self-injection. Now, the idea was, if you pair semaglutide with cagrilintide, this amylin analog, will you have additional weight benefit? And the answer is yes. So what you can see is that with the dose of 2.4 of cagrilintide and 2.4 of semaglutide, the weight reduction in just 20 weeks was 17.1%. And you can see that right here on this curve. And you can also see, once again, what happens when the medication is discontinued during the course of the trial. And so now CagriSema is moving forward in phase 3, and the redefined trials are well underway. Okay, so what's next? Glucagon GLP-1 receptor agonists. So an example of this is Tirzepatide. It's a GLP-1 glucagon receptor agonist. It is one molecule, not two, and it is also administered once weekly as a self-injection. So in phase 2 data that was presented at ADA just this past June, this agent demonstrated 18.7% weight reduction in 46 weeks, with 40% of participants losing at least 20% of their body weight at that time point. And so survodutide is also in phase 3 in the synchronized trial, and we are also fully enrolled here at Yale in that study. What about triple hormone receptor agonism? So retatrutide is a GIP GLP-1 glucagon receptor agonist. It is also a single molecule and also once weekly injection. I was also very honored to lead this phase 2 trial. And what we demonstrated and just presented the results this past June is that with the highest dose of retatrutide, the average weight reduction was 24.2% at just 48 weeks. So again, putting it into context, this is a shorter time frame. It's 11 months to reach almost a quarter, losing almost a quarter of your body weight at that time point on average. And again, participants were still losing weight at the end of the trial. And then obviously we'll have to see in the phase 3 when this is continued longer, what the maximum weight reduction can actually be. This translated to 58 pounds of weight reduction at just 11 months on average. And I'll show you, again, I've mentioned average a couple of times, and I'll show you what that means. But first, let's talk about the weight reduction thresholds. So for context, this 5% weight reduction threshold is something that the FDA uses as a marker for, is this medication efficacious or not? So this, if a medication does not reach this threshold, it will not be FDA approved. And again, this has to be reached by a certain percentage of participants in the trial. So in the retatrutide trial, 100% of participants reached this weight reduction threshold. And whenever I present this, I'm like, what is 100% in science? Nothing. So this is probably the last time I'll ever say 100% of anything. But for this medicine, that's what we found. 100% lost 5% or more. Now, what about the loftier weight reduction threshold? So 10, 20, 30%. So with the highest dose, the 12 milligram dose, I'll just highlight that data because there's a lot here. So 9 out of 10 lost at least 10%, nearly 2/3 lost at least 20%, and a quarter of participants lost at least 30% of their body weight. So now we're getting to weight reductions close to that we see with certain types of bariatric surgery. So really highly significant. And again, this is only in 11 months. We don't even know yet what the full efficacy is. Now, I've mentioned several times that there's variability in response. So here on this slide, what I'm showing you are waterfall plots. So this is each individual participant and their response to the various doses of retatrutide. And what you see is that most participants lost a substantial amount of weight with this agent. But there is variability in terms of the response. And this is the case for every type of obesity treatment. So this slide could depict bariatric surgery. It could depict liraglutide, semaglutide, tirzepatide. It could depict Contrave, which is naltrexone and bupropion combination, another medication we use for obesity treatment. And you might ask, well, why is this, right? Here's retatrutide 8 milligrams. You have some people who are losing 10%, and you have some people who are losing more than 40%. Well, obesity is a heterogeneous disease. There's not one type of obesity, just like there's not one type of diabetes. It's just that right now we don't have biomarkers. We don't have ways to determine how patients are going to be responding. We don't have a way to say you have this type of obesity and you have this type of obesity. But what we do think is that there's more than one type of obesity. There are many different types, and we need to work to figure out why that is. Now, there are clinical things that we can start to look at beyond, obviously, genetics, which is something that's going to help determine variability in response. But some of the clinical factors that we started to look at with retatrutide were body mass index and sex. We also looked at age. I'm just going to highlight here BMI and sex differences. So what we found was that participants with a BMI of 35, percentage-wise, lost less weight than those individuals who had a BMI of greater than or equal to 35. So basically, those who had more severe obesity tended to percentage-wise lose more weight. So absolute weight-wise, you would expect that, right? If you weigh more, you would, in terms of absolute terms, you would lose more. But percentage-wise, this looked to be the case as well. Now, what about sex? Does sex impact the weight reduction response? And the answer is yes. So with retatrutide, what we found was that the mean percent change in body weight was numerically greater in women than it was in men. So women in this trial at 11 months lost up to, on average, 28.5% of their body weight, whereas men lost 21.9%. And we don't know why this is. Is it the distribution of fat? Is it the amount of fat? Obviously, there's differences between men and women, and we need to understand this better. Now, one additional fact about this trial is, as I mentioned at the beginning, most of the trials enroll more women than they enroll men. And this is because more women present for enrollment. In this trial, we intentionally enrolled about 50% men and 50% women. Now, women lose more weight than men. So what we think is that the efficacy of this agent was actually dampened by the fact that we intentionally enrolled more men. So we'll see. Now we'll see in the next trials what it actually shows. Okay, so retatrutide is continuing in phase 3 in the Triumph phase 3 trials, and we are fully enrolled here at Yale as well. Okay, so all the medications I've talked about so far are once weekly injectable. I'm going to very briefly just show you that there are also oral medications in development. So oral semaglutide is already FDA approved for the treatment of type 2 diabetes at lower doses. What about this peptide in an oral formulation looking at higher doses? Well, presented also at the ADA this year, oral semaglutide up to a dose of 50 milligrams daily demonstrated an average weight reduction of 17.4% at 68 weeks. So this is very similar to what's seen with 2.4 weekly injection, and nearly 40% of participants lost 20% of their body weight. Now, what about small molecules, right? These are all peptides. They're degraded by our gastric enzymes. So what about small molecules that don't have that kind of an issue? Well, orforglipron is one such example. It is a small molecule daily oral medication. And what we found was that in this phase 2 trial, participants who received orforglipron lost up to 14.7% of their body weight on average at just 36 weeks, with half of participants losing at least 15% of their body weight at that time point. Okay, so in case your patients cannot take a weekly injection or they cannot take a daily oral, there's also a monthly medication in development. It's called MariTide, and it is a GIP receptor agonist and a GLP-1 receptor, it's a GIP receptor antagonist, and it's a GLP-1 receptor agonist. Now, don't ask me to explain how Tirzepatide is a GIP receptor agonist and this new medication is a GIP receptor antagonist. I don't think we actually understand the biology of how this is working. Dan Drucker was just here a few weeks ago giving internal medicine grand rounds, and I defer all questions to him. Okay, so we know now that these agents can achieve 15, 20, 25% total body weight reduction. But when we're treating obesity, we're beyond weight reduction. What we really want to achieve is improvements in health outcomes. And that is the goal. And for the sake of time, I'm not going to talk about, I'm going to breeze through this basically, that one of the things we haven't had time to talk about is the quality of the weight reduction, muscle versus fat. And activin receptor inhibitors, as I mentioned, may actually be part of the answer to this. So bimagrumab, Jastreboff, and SRK-436 are 3 such agents that are currently in development. And the idea is maybe eventually we can combine medications like nutrient-stimulated hormone-based therapies with activin receptor inhibitors to maximize the amount of fat loss while minimizing muscle loss or preserving muscle mass and function. So here we are. We are working to not just reduce weight, but to optimize health, and that is really where we meet in the middle for treating obesity. And so to close out, I'm going to show you what we think is potentially the way that we can help our patients with obesity on their weight and health journey, and thinking of them as a whole, and how can we really, really optimize their health. So first, as we're treating patients with obesity, we need to target the neurometabolic pathophysiology of obesity. So as we develop these agents, we need to understand what is happening in the brain better. We also need to consider that heterogeneity of obesities, and that we target different mechanisms for different patients. And I showed you that difference with retatrutide, and it exists for other agents as well. We need to consider factors in treatment selection. So we need to consider the severity of obesity. And right now, we don't have great ways to diagnose obesity, right? We're using BMI, which is a screening tool. It doesn't actually tell us anything about fat. So we need ways to be able to assess fat mass, fat distribution. We need to consider the obesity-related conditions. All of these medications that I just showed you have different mechanisms, and we need to know how to target which patients best. We need to think about the overall health and the metabolic profile of the patient, and we need to figure out what are our treatment targets. BMI cannot be a treatment target. It is not enough alone. It could be part of the target, but not alone. We also need to individualize combination therapy. So how did we know, or how did I know how to treat that first patient and what combination to use? We need to figure out how we can best operationalize that for more of our patients. What about optimizing health? So as I mentioned, there's no medicine out there that can help us eat more healthfully or move more. And so as we're starting these medications, we need to make sure we're prioritizing protein, we're prioritizing fruits and vegetables, we're focusing on physical activity and making sure that our patients are encouraged to engage in resistance exercise. We need to obviously reduce stress and sleep quality, which is very important for this audience. And I cannot stress enough how important this is. These are not weight loss drugs. These are anti-obesity medications that hopefully are targeting that obesity pathophysiology, but we really need to optimize our patients' health, and we need to focus on these. We need to consider the rate of weight reduction. So I don't have time to focus on this today, but really thinking about, as we're slowly up titrating the medications, it may actually be less beneficial to our patients if they lose weight very quickly. Will they lose more muscle mass that way? Are they more prone to having gallbladder disease, right? So gallstones and cholecystitis, which we see more with these medications, just as we do with bariatric surgery. So we need to figure out, well, what is an optimal rate of weight reduction? The quality of the weight reduction, which again, focusing on muscle mass that I didn't delve into today. We need to consider the negative impacts of losing weight, right? We've talked about all these positive things, but there are negative things. What about bone loss? What about vitamin deficiencies, muscle loss, and not just muscle mass loss, but function, right? So how do we minimize these? And of course, side effects. And we talked about that today, to start low and go slow. And then finally, within the context of all this, bias and stigma, and considering the psychosocial and psychological implications of all of this. And that is because our patients with obesity have faced bias and stigma and shame so unfairly for a disease that they did not choose to have. And now they're facing all of these same bias, stigma, shame for seeking treatment for obesity. And we need to be part of the change. We need to compassionately care for them and support them through this journey. And finally, really important, access and affordability. Right now, there are shortages. I mean, literally, the plants or the factories that make these medications, they can't be made fast enough for the demand. The cost is also very high for these medications. The demand is high, the cost is high. But all these tools that I just showed you, all these tools in development, what good are they if our patients don't have access to them? And so I think we all need to really advocate and help move that forward as well. And hopefully, as there's more competition, as there's more medications, and hopefully there'll be more actual medications available to our patients, hopefully we'll be able to treat them appropriately. So I'd like to thank all of my collaborators and everyone that I work with at YWeight, our new Yale Obesity Research Center. We do focus on the investigation of novel anti-obesity medications. We conduct clinical research, doing clinical physiology research, using these medications as probes to understand obesity physiology, conducting clinical trials, as well as patient outcomes research. So with that, check us out in the little QR code. And I thank you for all of your attention and for caring for our patients and treating obesity. Thank you.
Wonderful. Thank you very much, Ania.
My pleasure.
We have a few minutes for questions. I'm going to start off just because you brought up sleep apnea and the
Sure.
SURMOUNT-OSA. And this has us in the field very interested because we know for like 20 years now,
Yeah.
from pooled either medical weight loss studies or surgical weight loss studies, that you lose a certain amount of weight that has a fairly predictable reduction in the severity of obstructive. We call it the 10-30 rule.
Okay.
A 10% weight reduction is a 30%, and we tell our patients regularly a 10 to 20% weight reduction, which you're achieving with these medications, can half the severity of sleep apnea. Either eliminate it severe or eliminate it in mild to moderate patients, or completely or improve it in severe. But what has also we've learned over the last 5 years is that sleep apnea is not just an anatomic predisposition from obesity or upper airway structure, that there's a number of physiologic traits, how the muscles work and so forth. And I think it's going to be particularly interesting to see if these drugs may impact, is it just the weight loss, or are there other mechanisms that they may be working through?
I cannot agree with you more. I think for each and every one of these, so I was just at a cancer meeting this weekend and presenting on Monday night on these medications and the potential impact on the 13 types of obesity-related cancers. There's 13 cancers that are associated with obesity, and at least. And the question is, what are the direct and what are the indirect effects? So the direct effects of the mechanism of the medications themselves, like for example, on inflammation. And what are the indirect effects, meaning the impact of the weight reduction. And these are all things that need to be explored. So anyone who's looking for things to research, research this.
Yeah. 100%. And I think we've got some work with Brian and
Yes,
Silvio.
exactly.
And it's with these other, the SGLT2Is, which don't result in significant weight
Yes.
reduction. Some caloric negative balance,
Yes.
some weight loss, and there's still improvement. So there
Yes.
may be some mechanisms at play, and we should be looking at maybe some of the combination of these drugs.
Yes, exactly. And I didn't show the scale OSA, with liraglutide. And obviously the weight reduction is more modest, but there was still benefit.
Yeah.
Yeah.
100%.
So to your point.
Good.
Yeah.
Questions? Yes, Ian.
And I defer all OSA and sleep questions to Clar as well as to Brian if he's online, because I am an endocrinologist.
Thank you so much for the talk. I had a question. As we're thinking about these medications, I think a lot of us as pulmonary providers find that patients identify us as the person that they go to for all of their medical needs. And I'm wondering if you feel that it's appropriate for us to consider prescribing these agents ourselves, or if there are specific infrastructural additives that we need within our clinic if we're going to start them. But, for things like asthma, OSA, we know that weight reduction is going to improve outcomes. And so I've had the experience of folks who want to start a medication, and we talk about referring to the obesity center. And as you alluded to, even that stigma associated with, well, I don't want to go to the center. It's like, oh, well, this is somewhere that, they're going to only support you on this journey. And so I wonder about, us as providers, should we feel empowered to try starting these medications on our own?
Yeah, that's a great question. And that's also, so there's the Yale Obesity Research Center, but the clinic, the actual clinical center is the Yale Weight Management Center, the Yale Center for Weight Management, and the word weight again. And as we kind of come to terms with the word obesity, right? Words are really, really important, and we need to be really attuned to that with our patients and really kind of hold them wherever they are in that process. But in the same way, like there's the Yale Diabetes Center, we don't think of diabetes as a negative word. But anyway, to your point about your patients and wanting to come to our center, I think yes, in terms of the prescribing. I think if you want to start prescribing these, absolutely just do it in as well-informed a way that you can. So, start taking maybe, an obesity medicine course, come shadow us in clinic. So Brian is awesome. Patients love him. He's doing an amazing job, and he's board certified in endocrinology, obesity medicine, and sleep. So learn from your colleague, and if you're interested, I think a majority of care for obesity, it's already coming from primary care. And so primary care providers, they are the ones who are at the forefront, and they will be prescribing these medications if they're not already. Right now, there's these boundaries and barriers with, prior authorizations, and there's no doses and shortages and everything. That will even out. We just have to be patient. But I would say if you're interested in starting doing this work now, there's nothing holding you back. Just, educate yourself as much as you can. Always start low and go slow. And then, reach out to us with any questions. But I think, yeah.
Hello. Okay. Hi. Thank you so much. This was really fascinating. I feel like I learned a lot, and
Great.
I have a lot of questions, but I'm going to limit myself.
Mhm.
And your last slide, I think, was really, really helpful to address some of my concerns.
Yes.
My question is, there's been a lot of criticism of BMI and whether this is really the accurate way to
Yes.
to assess a patient's health.
Yeah.
And I think that there's a lot of variety, and you mentioned the heterogeneity in the last slide about patients whose BMI is 50, but they have no comorbidities of
Yeah.
these obesity-related conditions. And there may be someone with a normal BMI that has many of these
Yes.
comorbidities. And so where do you see the future of these medications being used and, targeting the population, as you were mentioning, just as we found that statins were helpful even in people that didn't have a high cholesterol? Is there going to be a world in which these medications are helpful for people with enough obesity-related conditions or metabolic syndrome-related conditions that don't meet a certain BMI, but are going to benefit from it, especially thinking about certain populations in the world that have higher rates of certain diseases that not affiliated with obesity? And on the flip side of that, so are there people that are going to benefit that are not currently sort of obese by our current criteria? And on the flip side, is there going to be a negative effect of people who are currently meeting criteria for obesity but have none of the comorbidities and use this medication anyway? Are they going to experience more of the potential negative side effects without any of the other positive benefits?
Yeah, I mean, I think that the field is trying to figure this out. I think the field recognizes obesity medicine, recognizes that BMI is insufficient. It can be used in conjunction with other things. And what we, are realizing is we need ways to assess adipose. Like, we need to know where it is, what it's doing. We need biomarkers. Like, we have A1C in diabetes. We don't have anything like that in obesity. We don't even have a way for people to come in and like, here's your percentage body fat. Like, we have bioimpedance. There's lots of problems with it. So we need to figure this out, right? So BMI is a screening tool. We've been using it as a diagnostics tool because it's inexpensive and we don't have better tools yet. So that's one thing. In terms of who will or won't get treatment, I mean, right now there's such a shortage and there's not guidelines in terms of this or that. And there's different approaches to it in terms of indications for other obesity related diseases or other indications. So the first one that we see right now is with semaglutide for cardiovascular disease, right? So with Medicare implementing that based on the SELECT cardiovascular outcomes trial, we have that first indication. Now, we'll see how the OSA trials come out. We'll see how the kidney trials come out. Like, we'll be able to have more data on that in a relatively short time span within the next few years. And then the question about like, well, your question about what if somebody has a BMI 50 but doesn't have any of these things? Well, so here's the thing. Maybe right now there's no problem with, let's say, knee osteoarthritis or hip osteoarthritis. But if you've had obesity from age, let's say 13, and now you're 40, that's many, many years of that extra functional impact, right? So there's different impacts of obesity that aren't just diabetes or aren't just OSA. There's many other things as well. And, this is coming from an endocrinologist, not diabetes centric here, right? So I think we're trying to figure that out. I think that the introduction of oral medications that can reach more people around the world that don't need refrigeration and things like that, and also cost. So the small molecules, if they can be simpler to be made than these peptides, right? Will cost come down? And, just for reference, I was in Australia a year ago and I asked them, how much does semaglutide cost here? And they said $35 a month. And I was like, wow. In the UK, $100 a month. So around the world, in terms of affordability and access for patients is different than here. And so we got a lot of work to do here.
Thank you so much for that wonderful talk. I was really impressed by the difference between weight loss between males and females
Yes.
in one of the slides that you showed.
Me
And
too.
I was wondering if you could maybe share your insights on what's the mechanism for that. Is it sex hormone related? Is it inflammation? What do you think makes such a big difference in the effect of the drug?
So my answer to that is, I don't know. I can tell you about some thoughts, but what I can tell you is that I really pushed for that figure to be in the main part of the manuscript of New England. And the very reason is because of your question, because I wanted investigators and clinicians to start questioning this and looking for those answers. And we often don't. So that was a huge thing. So thank you. You just validated that. I think it may be, so women, by BMI, they carry more fat. That's how we are created. And the distribution of how women carry fat is oftentimes also different than men. And then the point that you raised in terms of sex hormone differences, I think any of those could potentially impact that outcome. What we need to see is in terms of other medications within this class and others, there's a post hoc analysis looking at semaglutide, and it looks like this may also hold true. So this may be a class effect. It may be an anti-obesity medication effect. We don't quite have enough data yet, but again, hopefully that retatrutide study, that was another thing that it added to expand the field and the thinking. Thank you.
Could it have something, again, could it have something to do with sort of also social interactions with the environment for women versus men and how their set points are?
It could, and again, we don't, and the question is like, how are each of us impacted by the environment? There are people, right? There are people who have obesity, there are people who have overweight, and there are people who have, I don't like the term normal weight, because if most people have overweight or obesity, then what is normal weight, right? Like why? But there's no term yet. We need to think of a better one. Another term is lean, but then I'm like, you can be normal weight, but not lean necessarily. But let's say the group that is lean or normal weight. Those individuals, some of them are, have been implementing their prefrontal cortex to try and control every morsel of food that they eat for the rest of their life. Like that's a really hard ask. That's basically what we've been asking our patients unfairly. And then there's a group of people that actually just eat whatever and they just don't gain weight. So the question is like, why is that? Why is the environment not impacting them? Why, whether it's their genetics or epigenetics or nobody in their family ever had obesity, how is that? So we don't actually understand that interaction, and we don't know if there are sex differences with that, to your question.
We have so many questions, but
So many
we're
questions
going to
now.
limit it
Yeah.
because I know you have another meeting.
Yeah, it's okay. I said I was
Thank
going to
you.
be a little late.
So a couple of questions from the chat. You
Yeah.
you actually addressed a couple of the cost questions.
Yeah.
The differences across countries
Yes.
and maybe moving to these smaller molecules
Yes.
will help bring down the cost from the peptides.
And the competition. I mean,
And the
there's so
competition.
many medicines
Yes,
that, yeah.
100%.
Yeah.
Dr. Askanase bring up a question. Just last week,
Yes.
there was in the New England Journal of Medicine, again, GLP-1 and Parkinson's
Yeah.
disease. What's going on there? There's also, in terms of brain health, thoughts that maybe some of these pathways are also involved in addiction as well, clearly,
Yes.
and
Yes.
so forth.
Yeah.
Those are
Yeah, those are great questions. And these are all being explored. So in terms of brain health, there's, the interest grew kind of slowly initially, but is it related to inflammation? Like, what is it? And that's being explored. To your point about addiction, we know these medications are working with different parts of the brain. It's not just the hypothalamus. It's also reward and motivation areas of the brain. And so what we saw clinically is, patients taking semaglutide, some of them, they would go from drinking like 3-4 glasses of wine, let's say, to drinking like 3 sips of wine. And we were like, well, why is this? Well, potentially it's because they're impacting these reward motivation regions of the brain. And that's something that is currently being explored. And again, are we going to see this as a class effect? What is the impact going to be? And we don't know. We just have to keep looking.
Dr. Mosenin, who is one of our sleep specialists as well. I think your data suggesting those patients that stopped did have weight gain like
Yeah.
9 or 10% and
Yeah.
so forth, argues to the fact that these drugs may not be affecting the set point of obesity. And is there research on that topic? You know, how can we change that
Yeah.
set point?
So it's interesting, the word set point, and this is why I call it the defended fat mass
Defended fat
over
mass,
set
yeah.
point, although set point is used in the field, is because it's not set, it's mutable. So if
Yeah.
you think about it, we don't want it to be set. And here's why. You go through puberty. What happens? The amount of fat that you carry is increased. Somebody gets pregnant, maybe not you, Debbie, okay? So if a woman gets pregnant, her body fat increases, right? She gains weight to carry that baby, right? And it's physiologic. So adolescence, pregnancy, there are different times in our life. So there's not a set point. It can be mutable throughout our lives, right? Depending on what's going on. And we want it to be, we don't want it to be fixed. And so, so I call it the defended fat mass. It's because that's what your body is defending at that time. The idea is that the medicines don't reset it like to a permanent fixed new place. They re-regulate it or they bring it down to a place where you're carrying less fat, which may have improvements on your health as well. So that's the difference there. But again, an antihypertensive, does it fix your blood pressure to 120/80? Does it fix it to 90/60? No.
Shouldn't expect that.
Right. We shouldn't expect this of these medications now. Maybe someday we'll figure that out. But right now we don't have it figured out.
Bill.
Thank you for the talk. Hopefully this is a quick question. So do you, given the regaining of weight after the trial ends where people go on placebo or stop the drug, do you view this as a lifelong medication? Are you counseling patients about that in like an adolescence, or like, is this going to be the next 50 years?
So it's a great question. If I had another 20 minutes, I would have spent more time on physiology and exactly questions like this. So yes, I do, because obesity is a chronic disease. Now the question, because you raised, for example, an adolescent, the question is if we treat earlier. So for example, the Semaglutide Step Young trial that I mentioned, if we treat earlier before puberty, will that have more of an impact, a lasting impact on the defended fat mass? We don't know. Maybe those changes happen in utero. We don't know, but we won't know until we investigate. And of course, we're looking at safety and efficacy, but safety is always first. So yes, I counsel patients from the get-go. I've never, or I don't say never, but most patients ask, well, can I go off? And when they get there, we have that conversation, but we set it up in the beginning that they'll need some kind of treatment for their obesity. It doesn't have to be this medicine at this dose, but if it's working for them, most patients don't want to go off. What I do as a compromise is, let's say somebody wants to go off a medicine. I said, how about this? Let's go down on the dose and I'll see you back in a few months. And if that person comes back, most of the time what happens is they come back and they've gained back some weight, or they haven't and they're like, I'm using all my power to make sure that I go to the gym every day and that I eat only, hard-boiled eggs and vegetables, and I'm able to keep off that last 10 pounds. So they're using their prefrontal cortex. Rarely there are patients who we can decrease the dose and they don't gain back that weight. And then we can, try and titrate down. I have 2 patients like that out of the thousands that I've treated. So I'm not going to say never. There are, and again, there's variability in weight regain. So if you go off a medicine and you gain back 5 pounds and your friend gains back, 50 pounds, we need to understand that better. But right now, most people, because it's a chronic disease, just like for hypertension, you need to continue treatment. Thank you for that question.
Thank you, Dr. Joe. That was fantastic.
Okay. Thank you. Thanks for having me.